Okay, welcome back to part 3 of chapter 21 on blood vessel and circulation. So at the end of part 2, we just got done with talking about and introducing what filtration is, what reabsorption is, and what diffusion is, and in which end of the capillaries do you have, whether you have filtration or reabsorption. So now we're going to talk about how we get the idea of why filtration happens in the arterial end of the capillaries and why reabsorption happens with the venous venual end of the capillaries, by talking about the different type of pressures, and we'll do a little math, okay? Okay. And so how does blood go through capillaries and knows when to complete filtration and when to complete reabsorption? This all has to do with the different pressures along the capillary. We have already mentioned before that at arterial end of capillaries, the starting pressure should be about 35 millicurie, as you can see input in this image here. And by the time it reaches your venous end of the capillaries, your blood pressure should drop to be about 18 millicurie, and hence, since blood pressure is within the capillaries that we're talking about, we can also say that that is the capillary hydrostatic pressure we call CHP. Okay? So CHP goes from 35 to 18, going from arterial end to venous end, while BCOP is defined earlier as an osmotic pressure that is present due to the plasma proteins being in blood that can't cross capillary walls. So that value across the board on average is about 25 millicurie. So that's why you see this yellow here, seeing as 25, and it doesn't change as we move from the arterial side to the venous side. They're all 25 because we're just talking about this pressure has to do with the fact that there's plasma proteins within the blood, and if this is just a normal capillary, those plasma protein concentration is not going to change as it moves through the capillaries because they're too big to fit through those pores within the capillaries. And why it illustrate the arrows going from the outside to the inside is because, remember, this is osmotic pressure. Osmosis always go towards direction where there is more solute, okay? Last semester, I keep saying water always follows salt, okay? This will become even a bigger thing that I'll keep repeating when we get to the urinary system and the fluid electrolytes chapter. So need to get that used to that now, okay? So solutes will water, osmosis is movement of water, and it will always move in a direction to an area where there is a higher concentration. And because there's all these plasma proteins floating around within the blood, that's why there is an osmotic flow from the outside to the inside in this value of 25 millicurie. Now, because this is the difficult concept for this chapter, some people have some students have a hard time imagining this in their head. So I will provide a supplementary video on this, on capillary exchange, but the numbers, I don't know why, but I guess everybody is different in terms of average numbers. We went with these numbers here for 35 to 18 and 25 millicurie for BCOP is because that's what the book tells us. And in other videos online, they can have a little slight changes in these values. So never mind the numbers in these other supplementary videos or other videos that you find online on YouTube that explains capillary exchange. Those numerical values can change, but the overall process and which one is bigger, which one is smaller, which one becomes positive, which one becomes negative pressure, will always be similar across the board, okay, regardless what the numbers are, okay? So it doesn't matter that you're watching something else and they're claiming 40 to 20 and then the BCOP maybe 28, okay, or something like that. I don't know. But those different numbers doesn't matter, okay? what matters is whether it's a positive value or a negative value in the end, and whether there's increase or decrease in value. Okay, you know what I mean by the end of this. Okay, all right. So, like I said, BCOP stays as 25 millicurie and it does not change as it moves down from one end of the capillary to the other because the plasma protein doesn't come out of the blood. And hence, we can say that the net filtration pressure, now this is a formula you have to remember because you can relate different situations to this formula. The net filtration pressure, NFP, is equal to CHP minus BCOP. Okay, so it's always this formula here where the capillary, the difference between capillary hydrostatic pressure and blood colloid osmotic pressure is equivalent to your net filtration pressure. Now, if you go to the book and start reading this section, there will be an extra value called net hydrostatic pressure. I took that out of the lecture because I feel like that ends up not being an important concept in the calculation realm in terms of how to calculate this stuff. So instead of confusing you with an extra value to know, I took it out of the capillary exchange process. Okay, so it's not that we skipped over that part. It's just that it's not necessary, and I don't want to confuse you with another extra value. You have to know what that is. Okay, but we will talk about net hydrostatic pressure when we get to urinary system. So we'll just skip over that part for capillary exchange and just focus on the NFP value. Okay, so if NFP value after the subtraction is a positive value, that means filtration will predominate. Okay, they will occur where fluid will move from the capillaries into your tissue. So that's why you have this filtration arrow going out this way, in through the tissues, and then coming back in this way. Okay, so filtration means fluid moving in outwards from your blood capillary into your interstitial tissue. That's what into your interstitial fluid and tissues and cells. That's what filtration means. But if your NFP value is negative, that means reabsorption will occur and fluid will move from tissues and cells back into the capillaries. Okay, absorption. So hence that's why at this end you have fluid moving in words for reabsorption. Okay, so why do we have positive value NFP here and negative value NFP here? So let me talk about this in a bit. Okay, in a blanks slide. Okay, so you have capillaries. Okay, this is your arterial end, and this is your venual end of the capillary. This is your capillary here. Okay, so remember NFP at the arterial end, not NFP, CHP. CHP at the arterial end is 35 millicurie. I'm not going to write millicurie anymore because it takes up space and end up just looking very messy. So I'm going to keep it simple. And then CHP at the venual end, it's about 18, which means somewhere between the arterial end and the venous end, you have a value where CHP would be equivalent to 25 because it just kind of slowly drops to 18 as we go along the capillary. Now we just said BCOP is equivalent to 25 millicurie, and that stays constant throughout the entire capillary length. Okay, and we just said NFP is equal to CHP minus BCOP. So just do simple subtraction here. We're subtracting CHP with BCOP to figure out NFP at these different locations. At the arterial end, the NFP is up about positive 10. At somewhere around the middle, if you take 25 minus 25, you're going to get 0. And then somewhere down at the venous end, your NFP will be negative 7, because you take 18 minus 25 equals negative 7. And we said when NFP is positive, it is filtration. So that's why this one here being positive value is what allows fluid to move out from the blood into your interstitial fluid or tissues. Okay, so I'm just going to draw some tissues here. Okay, tissues, cells. Okay, and then you have somewhere in the middle where NFP is completely 0. When NFP is 0, there's no net movement of fluid at all. Okay, when you have NFP is negative value, then you have reabsorption of fluid that happens, okay, which is at this end, you do have a negative value, which is why I say it doesn't matter what those videos from other sources, what kind of numbers they're putting in there, as long as they get it, they're getting that same positive value. And the arterial end, somewhere in the middle, there's no net movement, and with 0, NFP being 0, and somewhere at the venous end, it should be negative value, then it is correct, okay? So negative value means reabsorption, which means fluid moves back in to the blood. Okay, so fluid moves from the tissues into blood. Okay, so fluid moves out, called filtration at this arterial end. No net movement somewhere in the middle. And then you have the venous end where blood is moving, being reabsorbed back into the blood. Okay, so that's how we dump off important stuff to our cells and able to reabsorb stuff that is not necessary, like waste material, from the cells back into the circulation. And then we can get rid of those waste material, either if it's carbon dioxide, then we're going to drop it off into our lungs. If it's something we need to excrete in our urine, we're going to go send those to the kidneys. Okay, so this is how capillary exchange is achieved within within our circulatory system. Okay, it's based on this formula right here. And what value of NFP do you get? Is it positive or is it negative? Okay, all right, let me come back. Okay, so this is what I was getting at here, where I talked about if we have somewhere down the middle where you have CHP is equal to 25 millicurie, you have no net gain in movement of fluid. Okay, so after we calculate all that stuff, then now we understand why filtration happens at the arterial end and why reabsorption happens at the venous end. And you can see that the maximum NFP for filtration is actually higher than NFP for reabsorption, because one is a positive 10 value, one is a negative 7 value. So that means usually a little bit more filtration happens compared to reabsorption under normal circumstances. So how is this capillary exchange affected under different conditions of the body for homeostasis purposes? For example, what happens if an individual was bleeding profusely and losing a lot of blood volume? Can our capillary exchange help us with this process, or help us in bringing back the homeostasis of blood volume and hence our blood pressure? Well, first thing that's affected when a person is bleeding profusely is the overall blood pressure. So when someone is hemorrhaging, for example, your blood pressure will decrease, which means your CHP value will also decrease. Now, if we look at this formula right here, that's why I say you have to know this formula. in order to give this relationship some thoughts, okay? So if CHP decreases, if CHP becomes a smaller number, what will happen to NFP? So you're subtracting BCOP from a smaller number. Your NFP is going to become a smaller value, okay? So you're going to lower your NFP when CHP falls, okay? So with NFP decreasing, okay, and a smaller NFP usually means reabsorption will be increased, okay? And what happens, which means more fluid will move from your tissues and cells back into blood, and in a sense, increasing your blood volume back up. This process is known as the recall of fluids, okay? Meaning that under special circumstances, we can recall more fluid back from our tissues to bring up our blood pressure and blood volume back to homeostasis, okay? That, again, another way our body can control those things other than vasodilation and vasoconstriction we talked about, okay? All right. Okay, so a second situation, what about dehydration? How is it affected? What are we affecting in this little equation here? And what will happen to try to bring things back to normal? So when an individual is dehydrated, their plasma volume will decrease, okay? And which means their plasma proteins will now become more concentrated, okay? If there's more plasma protein being concentrated, that means the solute amount increases, which means, are we going to affect CHP or BCOP? We're going to affect BCOP in this case, okay? So BCOP would increase because now you have more solutes per unit of volume, which means more osmotic pressure will be created. And in that sense, if now let's look at NFP equals CHP, and we're going to subtract it by a bigger number, what will happen to NFP when you're subtracting by a bigger number? Well, your NFP will also decreases, okay? So in that sense, this will again, because NFP gets smaller, more negative, it accelerates the amount of reabsorption that can occur. Again, recall of fluids from your tissues and cells when you are dehydrated. Okay, so in a way, because your circulatory system can detect that, hey, you're not having enough liquid in your body, okay, because of all these differences in osmotic pressure that you're resulting because of that, okay, and that's why then your tissues they're gonna take fluid from your tissues wherever there is to supply it back to the blood, so we can bring our values back up, okay, your volume back up within the blood, and hence blood pressure goes back up in the blood, okay, and this makes sense because you are dehydrated, so you need to recall fluid from somewhere. And if there's nowhere else, there's no IV fluid at the moment that's going to be given to you. At that moment, your body's natural homeostatic mechanism is to draw fluid from where they can, which is from our tissues, okay? And we'll come back to this idea when we get to fluid and electrolyte chapter as well. All right, so last situation here is what happens in a starving person. So you know how sometimes we will see pictures of children who are starving in countries that doesn't have enough, money or supply for food. So even though they are starving, but you see that they usually have a big belly. Okay, so why is that? Well, this can be explained by capillary exchange. Now, when one is in starvation mode, now I'm not talking about starving yourself for a meal or two, but we're talking about prolonged starvation, where it's going to affect even the plasma protein that's floating around in your blood, okay? So because you're not adequately nutrition, okay, so you're not going to have as much plasma proteins within the blood because you're not eating amino acids to make proteins. And that will cause your BCOP value to go down, okay? So we look back at our formula here, NFP equals CHP minus BCOP. If these values go down, we're subtracting this constant number by a smaller number. So what will happen to NFP? NFP will increase, okay, which then that means it will become more positive value, which means filtration is what predominates in the case when we have BCOP decreasing. And fluid will be moving out of blood into your tissues and cell. And we call this edema. Okay, and this is why you will see starving children with large bellies, not because they're full of food in there, is because they're starving, and more so is because their abdomen are full of fluid from edema situation due to the fact that they are having a decreasing BCOP values, and their NFP gets more positive and ends up fluid moves from their blood into their tissues instead. Okay, so make sure you understand how these three situations create different values of NFP. For hemorrhaging, you're affecting your CHP value. For dehydration, you're affecting your BCOP value. But whether your CHP gets smaller or your BCOP gets bigger, either case, they would both result in decrease in NFP, which means reabsorption predominates. Now, if CHP was to increase or BCOP decreases, okay, those will cause a positive or larger number for NFP, and that will lead to reabsorption of fluids from tissues, from your blood into your tissues in a case of edema. So you can see why people with high blood pressure can have cases of edema. Usually that's one of the signs too, is where they have swollen feet or something around their ankles, is because there's edema going into their feet due to this, what we're talking about here. You increase CHP, this becomes a bigger number. You subtract by the same number, NFP will become bigger because you're subtracting from a bigger number, and more reabsorption will happen instead. Okay, so that's what happens in these three different situations. Again, I will post a video that talks about how calculation of NFP and everything, but they may be slightly different numbers. I was able to find one that's able to explain it pretty well, but they're just different numbers. So, but I like the animations. I like the calculations they go through and the formulas that they explain just like me. So, that's the video I'm going to post on eCampus. Okay, in addition to what I went through here. All right, so we talked about how blood flow can change with vasoconstriction or vasodilation. But what triggers these mechanisms is the next question. First of all, blood flows through only about 25% of all vessels in capillary beds because there's actually not enough total amount of blood for blood to be flowing through every single capillary bed all at once that we have within the body. So this is a reason why capillaries have precapillary sphincters I talked about earlier, which will contract and relax to allow different tissues to receive blood at alternating times. And this rhythmic changes in blood vessel diameter is called vasomotion. And this type of blood flow through capillary beds can be coordinated via three ways: autoregulation, neural mechanism, and endocrine mechanisms that we'll talk about. And that's what I said last semester. This is why autonomic nervous system was the last chapter, because we talked a little bit about that, neural mechanism of autonomic regulation of cardiovascular system. We also talked a little bit about autoregulation, and then chapter 18, why we begin with that in this semester is because that's the the endocrine system is the drive behind all this stuff of keeping our body in homeostasis. All right, so autoregulation is when vasomotion is controlled locally, okay, by changes within concentration of chemicals and dissolved gases. So there are local vasodilators that will relax capillary sphincters, which will then allow blood flow to increase within that area. So when vasodilator happens, okay, or release into the capillaries, they will increase oxygen flow, decrease CO2, nitric oxide will be released, higher potassium ion and hydrogen ion. These are chemicals that are also released. There are chemicals that are also released during inflammation, which is why one of the things inflammation causes was vasodilation, okay? And local vasoconstrictors are prostaglandins and thromboxanes. When we already mentioned prostaglandins last one chapter when we're talking about blood and the effects of platelets and clotting. Okay, then that's why during the clotting process there was that vascular phase where vascular spasm happens, because that's in a sense is a vasoconstriction. Okay. So here it is talking about how homeostasis sometimes can be perturbed by either not enough oxygen level, or if pH change, or you have accumulation of carbon dioxide within the body that, or you have increased tissue activity or physical stress, high local temperature, etc. Okay, all of this leads to inadequate blood flow and blood pressure around that localized area, which will affect your precapillary sphincter, which will decrease in resistance and increase blood flow when we do vasodilation to restore blood flow back to homeostasis. Okay. So second method is via neural mechanism, where cardiac output and blood flow can be regulated by the cardiovascular center within the medulla oblongata. Now, the vasomotor center will allow vasoconstriction when norepinephrine is released, which stimulates smooth muscles of the arterioles to be constricted, okay, which means that's how we can constrict our blood vessels. Vasodilation is when nitric oxide is released, and which then relaxes smooth muscle. Make sure you understand or remember which is released for whether you have vasoconstriction or vasodilation, okay? The cardiovascular center of the neural mechanism will respond to either baroreceptor reflexes or chemoreceptor reflexes that we talked about in last semester. Baroreceptor reflexes will be triggered when those baroreceptors are activated due to a higher degree of stretch within, for example, your heart walls. These baroreceptors, remember, they're measuring pressure, okay, in a sense, in the application of blood vessels, blood pressure. So baroreceptors are located within the carotid sinuses for the brain, aortic sinuses for systemic circulation, and then you have the wall of the right atrium that monitors the pressure within the heart. So, for example, if they are able to detect a person's blood pressure gets too high, blood pressure rises, they will decrease your cardiac output by parasympathetic stimulation, which will then decrease your heart rate by release of acetylcholine, if you remember from last heart chapter, and also stimulate vasodilation throughout the entire system to bring your blood pressure back down to normal level. Now, for chemoreceptor reflexes, we're measuring the amount of oxygen, carbon dioxide, or hydrogen ions level. These reflexes will be triggered when those sensory neurons within either your carotid or aortic bodies are able to detect changes in either of these three values within the blood or cerebrospinal fluid. We'll talk more about how pH values is an important thing when we get to fluid electrolyte acid base chapter, and then carbon dioxide and oxygen when we get to respiratory system. But this is in terms of blood vessels, what do they do? So let's say if, for example, these chemoreceptors detects an increase in the amount of CO2 or decrease in pH, which means you're getting more acidic, or decrease on the oxygen level. All three of these things means that something has to work faster to get rid of the extra CO2 or for more O2 to come back in. So this will, tell the cardioaccillary center and vasomotor center to become stimulated, increase your cardiac output so you can pump blood faster to try to get blood circulating faster to dump off those CO2 and pick up more oxygen from the lungs to travel to the rest of your body. So vasoconstriction also happens, which will then altogether increase your blood pressure back to normal level and hopefully bring these chemicals level back down or back up to homeostasis. Okay, so this is the homeostasis chart for either when blood pressure is too high or when blood pressure is too low, and what happens in the body to bring back your blood pressure back to homeostasis, back down to homeostasis, or back up to homeostasis. So for example, if you have too high of blood pressure, baroreceptors will be activated or stimulated within the carotid or aortic sinuses. The effector will then be your medulla oblongata, which contains your cardiovascular center. Cardioinhibitory center will be stimulated. Let me erase that. Okay, and then your cardioaccillary center is inhibited because you're having a lot of high blood pressure, okay, and the blood pressure is too high, so you're not going to accelerate your heart anymore. And then vasomotor center will be inhibited. This vasomotor center inhibition will result in vasodilation. These two will slow down your heart, which means it will decrease your cardiac output. Both of these things here will both bring down your blood pressure back to homeostasis level. Now, when blood pressure is too low, your baroreceptor will actually be inhibited when it's too low. So remember this, that baroreceptors are stimulated at high blood pressure. Okay, and they're inhibited when you have low blood pressure. Okay, so the effector is pretty much the same stuff, but it's just in opposite mode. Your cardiovascular center for your vasomotor center, they will be stimulated to cause vasoconstriction. Cardioaccillary center will be stimulated, and cardioinhibitory center will be inhibited. And this will cause an increase in cardiac output, both of which will bring blood pressure back up to normal homeostatic value. Now for chemoreceptor, here's a homeostasis chart that detects an increase in carbon dioxide level or decreasing pH, more acidic levels, or decreasing amount of oxygen level. All three of these criteria will lead to the same effect. They will cause your chemoreceptors to be stimulated, which will then cause your respiratory center within the medulla oblongata to be stimulated to tell you to breathe faster. Your breathing rate will increase to try to get rid of that CO2, extra CO2, and try to take in more oxygen. Cardioaccillary center will be stimulated, which increases cardiac output and blood pressure to get your blood moving faster so we can dump off some of that, more of that carbon dioxide from your blood into the respiratory system. Your vasomotor center will be stimulated, causes vasoconstriction, which will also bring blood pressure up for that same purpose. All of which, whether it be your blood vessels here, your heart, and your respiratory center, will all ultimately bring your pH back up, oxygen levels back up, and decrease the amount of CO2 level, okay, to bring it back to homeostatic level. So that's why the cardiovascular system is very related to the respiratory system in that sense, okay? All right, and the third method of controlling vasomotion is via endocrine mechanism. So for example, we talked about ADH, antidiuretic hormone, which can be released from your neurohypophysis in response to low blood volume, which will then lead to vasoconstriction and also water conservation by your kidneys, because that's what ADH is for, is to reabsorb more water from your kidneys and elevate your blood pressure. Okay, by allowing more volume of water to be reabsorbed, it will increase your blood pressure back up by increasing that volume. Okay, angiotensin 2 is actually one of the products within a pathway for the kidneys as well, and we'll end up talking about this again when we get to the urinary system. But angiotensin 2, that pathway will end up stimulating the release of ADH and aldosterone. Both of which will promote reabsorption of water. We'll come back to this idea again, like I said, when we get to the urinary system and fluid electrolyte chapter. For now, this will be a quick introduction to this pathway. So when juxtaglomerular cells, we'll talk about what that is when we get to the urinary system, but those are specialized cells within the kidney that senses that there is a decrease in renal blood pressure. They will release an enzyme called renin, and renin will ultimately lead to production of angiotensin 2, which will then stimulate production of aldosterone, followed by stimulated secretion of ADH, which will stimulate thirst, stimulate cardiac output, vasoconstriction to bring your blood pressure back up. Okay. This is known as the RAS pathway that we'll talk about when we get to the urinary system. RAAS, RAS. So another hormone, EPO, as we learned from the blood chapter, can also be released by the kidneys when your blood pressure fall or if your oxygen level is low, which will induce vasoconstriction and production of red blood cells. And lastly, natriuretic peptides called AMP or BMP, A standing for atrial natriuretic peptides, B for standing for brain natriuretic peptides, those in the brain and the heart, because in a sense those are the two very important systems that is relying on adequate blood flow. They will produce, and in response to excessive stretching in the atrium or ventricles during diastole, okay, and reduce blood volume and blood pressure. Because what happens is these AMP and BMP is released is because they detect a sudden stretching of this heart. Okay, in the heart or within the brain, the arteries going to the brain area. And that means you have a lot of blood pressure coming through or a lot of blood volume coming through. So hence, to bring blood pressure back down and blood volume back down, you have to do the opposite of ADH and aldosterone. Okay, you will increase sodium excretion by your kidneys, promote water loss by frequent urination, increasing that urination frequency, reduce your thirst. We don't need to increase your blood volume anymore, and this will end up blocking the release of ADH and stimulate vasodilation, all of which together will bring your blood pressure back down when it's too high. Okay, so this is what summarizes what I was just talking about in terms of how endocrine system is able to regulate our blood pressure. When our blood pressure or blood volume is too high, this is what needs to happen. Your cardiac muscle cells, first of all, will release AMP and BMP, which in a sense is working in antagonistic relationship with ADH and aldosterone. Okay, they do the opposite. Okay, so AMP and BMP will tell your kidneys and blood vessel to act in response. For kidneys, they will increase sodium loss, increase water loss, and then they will also reduce thirst. Okay. They will also stop the release of ADH, aldosterone, and epinephrine and norepinephrine, and cause for blood vessels. They will cause vasodilation to bring your blood pressure and blood volume back down. So when your blood pressure is too low or your blood volume is too low, there are two effects. One is short term, one is long term. Short term is regulated by baroreceptors we talked about that will activate sympathetic activation. That's why there's that momentarily of us feeling like superhuman that I talked about, okay? to release epinephrine, norepinephrine, which acts on the heart to respond with increased cardiac output and vasoconstriction to bring up the blood pressure. For kidneys, is more long-term effects. We're looking at more EPO is released to stimulate red blood cell formation, which will increase the amount of blood volume there can be. Renin will lead to angiotensin II activation, which leads to ADH and aldosterone being activated and secreted. Thirst is also stimulated, all of which will then lead to an increase in blood pressure back up. All of these things here will then be allow for increase in blood pressure and volume back to homeostasis, okay? Which is why I was saying these homeostasis chart, you'll see multiple of them in multiple chapters, and they become a very important core of AMP2 is how do we regulate homeostasis? What hormones or protein peptides is involved? What are the effectors? What do they do to bring things back to homeostasis? Okay. All right. So we will end this chapter by going over 3 special circuits that are slightly different from our unusual circulation scheme. First of those is called the pulmonary circuit that we have already talked about and discussed from last chapter on the heart. What's different with this is remember that we have pulmonary artery versus pulmonary vein, and how it's reversed in terms of oxygenated and deoxygenated blood, because we're naming these by whether they're moving away from the heart or towards the heart. So pulmonary circuits starts when blood enter into the right atrium, and then from the right ventricle is where pulmonary circuit will start and push blood into the pulmonary trunk through pulmonary arteries into the capillaries of the lungs, okay, left and right pulmonary arteries, and then they will come back as oxygenated blood through pulmonary veins through your right atrium into your left ventricle, okay, into your left ventricle, and from your left ventricle is the start of your systemic circuit, which will pump blood through your aortic valve into the aorta through the rest of your artery system around the circulation, okay, around the circulation system. Okay, so we already know very well with pulmonary circuit, and now the next unique circuit is something we have already talked about between the hypothalamus and the adenohypophysis. Remember the hypophyseal portal system, but now we are talking about the liver. So this is called the hepatic portal system. Hepatic for liver usually, and then portal system means it is carrying blood from capillary network directly to another capillary network. And because the liver is the main important organ that is able to cleanse and detoxify the things that we ingest, everything that is absorbed from the stomach, small intestine, and large intestine all have to go through towards the liver. You see these veins here all have to drain back to the liver first before they can head back into the venous circulation towards the heart via the inferior vena cava. So this is why we have all these capillary networks around the digestive organs that all leads to the liver's capillary network. So if there are things that need to be stored or need metabolic conversion or need excretion, they will be processed through the liver. Because so many things are coming into the liver, big or small, this is why the liver have a lot of sinusoid types of capillaries that I was talking about earlier, okay? And hence the hepatic portal vein right here, hepatic. Now, don't confuse hepatic vein with hepatic portal vein. This is the hepatic portal vein. This is the hepatic veins. Okay, hepatic veins collect blood from the liver itself back into the inferior vena cava. Hepatic portal vein connects all the capillary network from these different areas into the liver to be cleansed first, and then goes back up the inferior vena cava. Okay. So the hepatic portal vein will receive blood from 3 large veins for 3 main areas of the abdominal area for digestive organs. You have the inferior mesenteric vein, which is this one right here, this one. Okay, so this is the inferior mesenteric vein, this one right here, okay? Inferior mesenteric vein that collects blood from your large intestine. So that's why this vein leads into the large intestine and towards the rectum here. Splenic vein is easy. It starts with spleen. So of course it leads into the spleen right here. Spleen is always kind of squished off to the side next to the stomach. So this is the splenic vein that's coming out of the hepatic portal vein. And then, it also branches into the superior mesenteric vein. Okay, so this is the superior mesenteric vein right here. Okay, that will collect blood from the stomach. Okay, you see how this little branch kind of goes up into the stomach here, and then you have the small intestine right here, and then 2/3 of the large intestine. Okay, what they cut off is the transverse colon so that you can see what's underneath the transverse colon, such as the pancreas, and the 3 branching of the hepatic portal vein. Okay, so it goes into splenic vein, inferior mesenteric, and superior mesenteric. Okay, and make sure you know what organs these 3 veins serve. Again, the goal of the hepatic portal system is to regulate those nutrient content of blood before it enters your venous circulation via your inferior vena cava. Okay, and the last unique type of circulation we have is called the fetal circulation, where the way things work for babies when they are still in the mother's womb works very differently from when they are born. So when a baby is still within their mom's uterus, the baby's lungs are actually collapsed, which means they are non-functional. They don't breathe in and out like we do, okay? And they don't need to breathe in any air per se. So that's why their lungs is non-functional. They receive oxygen directly from the mom through the placenta and drop off carbon dioxide in that same manner. Now their digestive tract also have nothing to digest. Okay, which means they don't need a lot of blood moving into that area either. They're absorbing their nutritional stuff all from the mom via the placenta as well, which is pretty much everything the baby is forming and needing for growth and development is coming from the mom. And hence there are a few unique structures that are present in the fetus's cardiovascular system that would disappear after they are born. But while they're still in mom's womb, they have to rely on these few structures to ensure that they have adequate amount of oxygen and that they are, their lungs are collapsed. So they have, they're receiving oxygen and dumping off carbon dioxide to the placenta in the right direction, and how they're able to receive nutrients. Okay. All right. So the umbilical, let's start with the placenta. So first, the baby will receive oxygenated blood from the mother through the placenta right here. So oxygenated blood will go through the umbilical vein. Now, we call it vein because we're talking about blood flow with respect to the baby's heart. And this blood is traveling towards the baby's heart. So the red vessel that you're seeing right here is called the umbilical vein. Okay, so this is the other exceptional, kind of like pulmonary arteries and pulmonary vein, where vein is detected as red and arteries is detected as blue. Okay. All right, so the umbilical vein will carry the necessary oxygen and nutrients to the baby, and then it drains into what's called the ductus venosus, okay? Ductus venosus to collect blood from the baby's liver's vein and move up into the inferior vena cava. So in a sense, the inferior vena cava carries partially oxygenated blood toward the baby's heart. You see how it's kind of purple around here, is not red or blue because there's a blend of the two. Now this is very much different from the adult circulatory system because all the blood going into the inferior vena cava for a baby that is born or an adult, it should be deoxygenated. Okay. Now, because the baby's lungs is non-functional in the mother's womb, blood actually do not need to go through the lungs. So two unique structures that are present for blood to bypass the lungs or pretty much skip over the pulmonary circuit, those two structures exist. Okay, so first, an opening exists between the right atrium right here and the left atrium right here, and you see that little black circle right there, that's the opening, and it's a hole that's called foramen ovale. Okay, so a second extra structure that exists for fetuses is an opening that sits between your pulmonary trunk. Okay, this is your pulmonary trunk, and there's an opening right here that goes from the pulmonary trunk. You can go through here to the aorta straight. Okay, this doesn't exist in a baby that is born or in an adult. Okay, because we want to separate the pulmonary trunk from the aorta. But this little shunt here from the pulmonary trunk to the aorta is called the ductus arteriosus, so that blood doesn't have to go into the pulmonary arteries. They can travel into the aorta directly and move on to the rest of the baby's body. So both of these openings, our ductus arteriosus and foramen ovale, is what allow blood to travel from the umbilical vein directly to the aorta to be distributed to the rest of the body's artery, the baby's body's arteries throughout the entire system. And blood will then drain back towards the placenta once they become deoxygenated this way or this way, and they will go back into the umbilical arteries, okay, moving away from the baby's heart. Okay, we're going away from the baby's heart back towards the placenta in this purple line right here, and where carbon dioxide, waste material will be dropped off through the placenta. Okay, so from umbilical arteries, ductus venosus, inferior vena cava, into the heart, doesn't go through the lungs, skip over the pulmonary circuit, go straight into the aorta, travel back downwards, into your umbilical vein, and then goes back to the placenta. Okay. Don't forget ductus arteriosus and foramen ovale is what allows blood to go straight into the aorta as soon as possible. Now, once a baby is born, though, when they take their first breath, lungs and pulmonary vessels will be allowed to expand. Blood will rush into the pulmonary vessels, and that rising oxygen level will stimulate constriction of the ductus arteriosus that existed there, and then it becomes closed once you have all that pressure coming through. And now you will be able to isolate the pulmonary trunk from the aorta. Blood no longer travels from the pulmonary trunk into the aorta. If that happens, we'll be in trouble. We're going to mix oxygenated with deoxygenated blood all the time. And the other thing is we need to close up the foramen ovale. So as pressure rises in the left atrium due to the fulfillment of pulmonary circuit, the foramen ovale will shut close, and a shallow depression mark the site, at around the right atrium area in the interatrial septum marks where the foramen ovale was when you were still a fetus in your mother's womb. Okay? All right. Okay, so unfortunately, there can be malformation of the heart and its associated great vessels during development of an embryo, which is collectively what we call congenital heart problems. Here are a few conditions that can happen. First one of those is called patent foramen ovale, and you might have heard of this before, where the foramen ovale, after the baby is born, it remains open instead of closing nicely like that. Blood then recirculates through the pulmonary circuit instead of entering your left ventricle. Your heart ends up having to work harder to provide blood flow through the systemic circuits because blood from the left atrium goes back into the right atrium. Okay? And the circulating blood is not oxygenated adequately because of this backflow of blood, and you would end up with cyanosis that we talked about for the integumentary system that results in what we call blue baby. And why blood flows in that direction is, remember that the left ventricle is pushing at a much stronger pressure than your right ventricle. But because this is a side with a stronger pressure, that's why it will squeeze. Blood will go this way from the left atrium into the left ventricle. Okay. Tetralogy of the phalate is another example where the pulmonary trunk is abnormally narrow like that, and on top of that, your interventricular septum right here is incomplete, which means now you have blood flowing between the ventricles. Okay, so aorta will originate where the interventricular septum normally ends. So the right ventricle is now enlarged because it's trying to push with a lot of pressure. And both ventricles end up being thickened due to the increased workload you have to have in order to supply enough oxygenated blood to the rest of the systemic circuits, because you have this mixing of blood between oxygenated and deoxygenated. Ventricular septal defect is an abnormal opening within just the interventricular septum. So it can be similar effect as your foramen ovale. Again, why we have blood, more so the blood flowing into the right ventricle is because the left ventricle is pushing with more pressure. Okay. So ventricular septal defect is different from tetralogy of phalate, where tetralogy of phalate have an additional pulmonary trunk malformation, whereas this, we're just talking about incomplete interventricular septum. And then atrioventricular septal defect is when both atria and ventricles are incompletely separated. The result depends on the extent of defect, but this is very common, or most common, in Down syndrome babies. Okay, and that's why sometimes Down syndrome babies may grow, but they may end up with a lot of heart problems because of that. Transposition of great vessel is a pretty scary thing, where the aorta right here is connected to the right ventricle instead of the left ventricle. Pulmonary trunk is now connected to the left ventricle instead of the right ventricle. Okay, so the pulmonary artery is right there. So instead of from right ventricle to the pulmonary trunk, now it goes to the aorta. And then systemic circuit, it comes into the left atrium, left ventricle, and it goes into pulmonary trunk and goes back into the pulmonary circuit. So this, you can see why this can be a big problem, where you have the two great vessel, which is your aorta, and your pulmonary trunk reversed in what they're connected to. Okay. All right, so let's go through. That's all I have for you for chapter 21. It's a long chapter. A lot of stuff, complicated stuff to go through. We'll go through these practice questions and we'll be done with this chapter. Okay, which of the following is an important characteristic of capillaries? Blood flows through them slowly and exchange occurs quickly. Why are valves located in veins and not arteries? Is because venous blood pressure is lower and valves are able to prevent that backflow of blood from fighting gravity. Georgia stands all day at her job. From what condition may she begin to suffer? What is the cause? Varicose veins due to valve dysfunction. While standing in the hot sun, Sally begins to feel lightheaded and faints. Why? This is what we talked about in terms of locking your knees. Blood has pooled in your lower limbs. Cardiac output has decreased, sending less blood to the brain. And because she's standing out in the sun, she's also dehydrating due to sweating. Which of the following is a unique character? All of which is going to lead to a decrease in cardiac output, and that's why she ends up fainting. Which of the following is a unique characteristic of arteries when compared to veins? Arteries contain that internal elastic membrane to produce that rippled characteristic in their tunica intima. The heart and arteries, so systemic and pulmonary circuit, contain 35% of blood volume, and the venous system contains 65, which is why I said this is 2/3 of the blood volume. This is about 1/3. And this is because of that high capacity of veins serving as our blood reservoir. Why is blood pressure higher in the aorta than the inferior vena cava? Because the force exerted by the left ventricle to push into the aorta is greater than that exerted by the inferior vena cava. Why does most filtration takes place at the arterial end of a capillary? Because CHP is higher at the arterial end. That makes NFP positive. What event is happening if net filtration pressure is negative? Then reabsorption happens, and that occurs in the capillary, where fluid move from the tissues back into the capillaries. Although it is true that capillary arteries carry blank, it is not always true that they carry blank blood. Artery always carry blood away from the heart, A for array, but it is not necessarily always carrying oxygen-rich blood. Sometimes it's carrying deoxygenated blood. The hepatic portal system delivers nutrients to the liver. In fetal circulation, what is the role of ductus venosus? They collect blood from veins of the liver and empty them into the inferior vena cava. A patient in the ER has lost 1.5 liters of blood. Which of the following helps restore venous return and improve cardiac output? Both A and C. Secretion of epinephrine and norepinephrine, fight or flight sympathetic nervous system, causes constriction of arterioles, vasoconstriction, and then mobilization of venous reserve, venoconstriction, to result in recall, and also recall of interstitial fluid. We talked about in capillary exchange. Which of the following is an example of a local vasoconstrictor? Prostaglandins. And that's all I have for you for this chapter. See you.